Fundamentals of clinical dermatology. Morphology and special clinical considerations. In addition to primary morphology and secondary changes, other lesional characteristics is critical in narrowing a differential diagnosis. Color. Color is a crucial additional feature after primary morphology. Subtle variations in hue and saturation provide meaning. Common colors include brown in hyperpigmentation and red in erythema. Implications of color changes. White lesions indicate reduced or absent melanin synthesis, keratin, calcium deposits, or scarring. Diagnostic examples: tinea versicolor, vitiligo, loss of pigment; milium, keratin-filled cysts; calcinosis cutis, calcium deposits in skin; atrophy blanche, white scar-like patches from poor circulation. Black lesions usually reflect dense melanin, hemorrhage, necrosis, or oxidized keratin. Examples include melanoma, dense melanin; talon noir, intraepidermal hemorrhage from trauma; cutaneous anthrax, necrosis; open cum dun, oxidized keratin, that is, blackheads. Brown lesions represent melanin deposition in the skin. Common examples: melanocytic nevus mole; melasma, hyperpigmentation due to hormones or sun exposure. Red-brown lesions. More varied causes including hemosiderin, granulomatous inflammation, histiocytic or plasmacytic inflammation, mast cell infiltration, mucin or amyloid deposition, or smooth muscle infiltration. Clinical associations: pigmented purpuric dermatosis, hemosiderin; sarcoidosis, apple jelly nodules; Langerhans cell histiocytosis; granuloma facial; secondary syphilis, copper-colored lesions; urticaria pigmentosa, mast cell infiltration; pretibial myxedema, mucin deposition; lichen amyloidosis, amyloid deposits; cutaneous leiomyoma, smooth muscle; subacute lupus erythematosus, chronic epidermal inflammation. Red lesions indicate vascular dilation or congestion, neutrophilic inflammation, or vascular tumors. Examples: erysipelas, vascular dilation; Sweet syndrome, neutrophilic inflammation; cherry angioma, vascular neoplasm. Pink or salmon lesions reflect acute inflammation with dilation of superficial dermal vessels. Seen in eczema, drug eruptions, urticaria, psoriasis, and pityriasis rubra pilaris. Yellow lesions. Multiple possible causes: pus, lipids, histiocytic inflammation, elastolysis, sebaceous glands, and bilirubin. Examples: folliculitis pus; xanthelasma lipid; necrobiosis lipoidica, histiocytes; pseudoxanthoma elasticum, elastolysis; sebaceous hyperplasia, sebaceous glands; jaundice, bilirubin. Green lesions arise from deep hemosiderin, bacterial pigments, or eosinophil or myeloperoxidase activity. Seen in ecchymosis, deep hemosiderin; Pseudomonas infection, pyocyanin; chloroma, myeloperoxidase; Wells syndrome, tissue eosinophilia. Blue or gray lesions represent deep dermal melanin or other pigment deposition. Examples: blue nevus melanin; argyria tattoo, foreign pigment. Violet to lilac lesions indicate acute lymphocytic inflammation with dilation of deep dermal blood vessels. Found at borders of morphea, dermatomyositis, lichen planus. Plum lesions associated with vascular neoplasms, dense lymphocytic inflammation, malignant tumors, or hemorrhage. Examples: Kaposi sarcoma, lymphoma cutis, nodular melanoma, ecchymosis. These pictures show purple papules in Kaposi sarcoma, violaceous Gottron papules, yellow in necrobiosis lipoidica diabeticorum, red in erythema multiforme and eschar overlying stellate purpura. Other lesional characteristics. Shape and configuration of lesions include shape, which describes an individual; configuration, which is shapes made from arrangement of primary lesions; and demarcation refers to the edge of an individual lesion. Specific configurations may be annular, round nummular or discoid, arcuate, or linear. Specific configurations include geographic, reticular or retiform, stellate and targetoid, typical targets, atypical targets, and annular, whorled, grouped or herdiform, scattered, and polycyclic are the specific configurations. These pictures show annular lesion in granuloma annulare, reticular eruption in livedo racemosa, nummular lesion in nummular dermatitis, serpiginous erythema in jellyfish sting. Lesional distribution is also critical in diagnosis, whether it is dermatolmal in zoster blaschcoid, lymphangitic and sporotrichoid, photodistributed, sun-protected, acral, truncal, extensor, flexor, intertriginous, seborrheic, follicular, localized, generalized, bilateral symmetric or universal is important determinants of the differential. Groups of diagnoses that share similar morphologic characteristics are termed reaction patterns, which is especially useful tool when no characteristic shape, configuration, or distribution is apparent and can also help guide workup and initial treatment. Reaction patterns without surface changes are macular, dermal, subcutaneous, purpuric and erythemas. Papulosquamous reaction patterns show thin, flat-topped papules or plaques with scaling well demarcated. Psoriasis, lichen planus, pityriasis rosea, secondary syphilis, and tinea corporis. Eczematous reaction patterns show thin, red papules and plaques with epidermal changes. Acute, serous crusting, microvesicles or bully. Subacute or chronic, dry, scaly, fissured or thickened and ill-defined with varying sizes and spacing. Vesiculobulous reaction patterns has vesicles and bully and footprints of blisters. Dermal plus reaction patterns has infiltrated papules, nodules or plaques, and surface changes. Macular reaction patterns are color changes. Pink and red to brown, white or gray or blue. Dermal reaction patterns are papule or plaque without surface change. And subcutaneous reaction patterns are a deeper papule or plaque in the subcutis. Purpuric, red or purple lesions. Do not blanch with pressure. Petechiae, small purpuric macules. Ecchymoses, large purpuric patches. And palpable purpura reaction patterns are raised purpuric papules. Erythemas are blanching red-pink macules, patches, or plaques. Morbilliform are symmetrical, diffuse blanching pink or red macules and papules. And figurate are annular, arcuate, or polycyclic blanching plaques. Urticarial are pink, blanching macules, papules, or plaques with a characteristic wheel and flare. And targetoid are at least two color zones, including a darker center with a dusky hue. These pictures show retiform purpura with ulceration and eschar. Urticarial phase in bullous pemphigoid. Cutaneous diagnostic signs. Apple jelly sign, it is a yellowish hue from pressure on the lesion with a glass slide. Occur in granulomatous processes. Aspo-Hansen sign is lateral extension of a blister with downward pressure. Blistering disorders above basement membrane zone. Auspitz sign is pinpoint bleeding at the tops of ruptured capillaries, with forcible removal of outer scales from a psoriatic plaque. Buttonhole sign is a flesh-colored soft papule feels as though pushed through a buttonhole into skin, and occurs in neurofibroma. Carpet tack sign is horny plugs at undersurface of scale removed from a lesion, and occurs in chronic cutaneous lupus. Derriere sign, urticarial wheel after firmly rubbed with a finger or rounded end of a pen. Urticaria pigmentosa and rarely cutaneous lymphoma or histiocytosis. Dermatographism, firmly stroking unaffected skin, producing a wheal within seconds to minutes. Occur in hisical urticaria. Pseudoderrier sign is transient induration of a lesion or piloerection after rubbing. Occur in congenital smooth muscle hamartoma. Fitzpatrick dimple sign is dimpling of the skin with lateral compression with thumb and index finger as a result of tethering of epidermis to dermal lesion, which is characteristic of dermatofibroma. Nikolsky sign, lateral pressure on unblistered skin resulting shearing of epidermis. Occur in blistering disorders above basement membrane zone, in pemphigus vulgaris and toxic epidermal acrolysis. Conclusion. The basic art and science of morphology remains paramount in dermatology to achieve accurate diagnosis and a deeper understanding of clinical pathologic correlation. Careful evaluation of the skin and systematic identification of primary morphology, secondary changes, and reaction pattern is essential to the art and science of dermatologic diagnosis.